I'm thinking because we're a relatively small group that it might be not too time consuming to do some introductions, if that'd be all right. So I'm Helen Phillips Jackson. I'm Deputy Director for Scheduled and Planned Care, and my portfolio of services are the forensic and rehabilitation services, as well as building successful families. But aside from my portfolio of services, I'm been asked to provide the trust management coordination lead on the CMHT consultation and process, which is why I'm delivering this session today. I'll start using the right words soon. So if I just read people's names in the order that I've got them, and you could introduce yourselves, that'd be really good. So I've got Alice first.
Hi, my name's Alice Mazzoni. I'm an improvement facilitator with the quality team.
Great, hi. Esther, who I know, obviously.
Hi, I'm Esther. I'm the admin buildings manager at Eastglade.
Hi, Esther. Gurka.
Good morning. I'm Gurka Lange, and I'm a clinical leadership fellow working with the quality improvement team.
Okay, thanks. Heather.
Hi, I'm Heather Smith. I'm a non-exec director, so sit on the board.
Hiya. Helen.
Is it me?
Yes,
Helen
sorry.
Cowpig. I'm the service manager of HAST. I'm walking in, so and I'll have to leave at 10. So, but we work with homeless people and support them with their mental health.
I'm just impressed that you're walking and engaging in this. That's beyond my capability, I think, of multitasking.
Okay.
Jo.
Hi, yeah, I'm Jo Evans, continuous improvement manager.
Thanks, John.
Hi, I'm John Williams. I'm a clinical administrator at the single point of access.
Hi, thanks, John. Jonathan.
Hi, Jonathan Burley. I'm clinical effectiveness manager working at Fulwood.
It's Lee.
Sorry, was that Lee?
Yes, yeah.
Sorry.
It's all right.
Well, I'm Lee. I'm Lee Alexander. I'm an improvement facilitator working within the quality improvement team.
Yeah, thanks.
Liz. Okay.
Hi everyone, I'm Liz, caterer. I'm contracts and bid manager at the Trust.
Thanks. Michelle.
Morning everybody. Hi, I'm Michelle Horsepool. I'm Deputy Director of Research for the Trust.
Yeah, Mike.
Hi, I'm Mike Atter, one of the consultants in the recovery team. Morning.
Hi, Mike. Mike's heavily involved in the review, so no doubt he'll have some good contributions as well. Richard.
I'm Richard Mills. I'm one of the 3 non-exec directors on this call, so I'm a part-time member of the board, but I'm the only one of the 3 that was involved in the original decision to go ahead with community services reconfiguration. So I have a lot of history about all this. So that's one of our interests, and something the board we're very keen to keep a close eye on and to help support you guys.
Great, thank you. And Sandy.
Morning everyone, I'm Sandy Keane. I'm the 3rd non-exec director on this call. I also chair the quality committee, so we discuss CMHTs and community services a lot, and I'm really keen to, like Richard, support everybody in terms of re-looking at our offer and the pathways to make sure they're as good as possible. So thanks.
Great. Thank you. I think that's everyone. If I've missed anyone, please stick your hand up, but I do think that that's everyone from my list. So thanks for doing that. I think as it's a reasonably small group, it's usually worth knowing what people's positions are and what their particular interest is in this session. Okay, so I will crack on now. Jo, I can see the slides. Thank you. So yeah, I think Jo's covered most of the information about if you can mute your microphone when you're not speaking. I will inevitably start speaking when I'm muted, like everybody does at some point. So I'll work it out eventually, or wave at me. As Joe also said, with the cameras, can have them on or off, or whatever feel you're most comfortable with. Obviously, I don't always feel comfortable having it on the whole time, but as I'm presenting, that seems appropriate for today. Joe's going to sort the slides for me. There's not many because I think a discussion is probably more useful. But can we try and use the hands up function if you do want to ask a question, and I will do my very best to multitask and make sure that I take people in the right order. But if I don't, apologies. And yeah, as for SHSE staff, turning off your VPN might improve stability of the connection. So if you don't mind going on to the first slide from the presentation, Joe. Okay. I've crammed quite a lot into that slide, but there is only a couple. So as you all know, I suppose a bit of context that might help as well is that I'm quite new to the trust. I joined in February of this year, and my previous role was as the Substance Misuse Commissioner for Sheffield City Council. So I was responsible for the commissioning and performance management of the Sheffield Substance Misuse Services, and also for writing the council's strategies on drug and alcohol policy responses. So as part of that work, I led large scale change processes, including retenders, and I think that kind of experience, along with being new to the organisation and not around when the original reconfiguration was done, was one of a couple of the reasons that I was asked to kind of work on this project. So as you all know, the services were reconfigured back in 2017, long before my time here started. Obviously, I can't comment on the specifics of how that was done. Obviously, I know a lot of you probably have more information about that than I do. However, the subsequent industrial dispute about issues relating to the outcome of the review and how the model was working led to an agreement to deliver a review of the model, which would be jointly kind of overseen by a trust manager, which is me, and a staff side manager, which is David Pickersgill. And Philip East Hope is the executive sponsor and the chair of the project group. So that's the kind of hierarchy governance situation. Philip's the overall owner of the piece of work, and David and I are responsible for making sure that it happens. So the tour was agreed and work began in June 2020. I believe probably there might have been an intention to begin work before that, but there was a little pandemic that we've all been dealing with, so it's been difficult to do business as usual. So we started work in earnest on it in June. The services in scope of the review are the North Recovery Teams, SPA and EWS. It's worth noting, of course, that there's complications and multifactorial issues to consider about us doing a review of those services, because they're all part of pathways with other services as well that aren't in scope of the review. So that's something that we're well aware of, and in communication with the CCG, who are on the project board, about, because it's not just as simple as us saying we want to do something differently in this way. It does have ramifications elsewhere in the system, and it does need to fit into the wider system. So obviously, I always think the only way to really be able to do a simple bit of change management is to be able to stop time, so that we can rearrange everything and then just press the play button. But obviously, as no one's invented that yet, we have to try and deal with all of these complexities that present themselves. So there's a project board, which initially when we were getting the work started, they were taking place fortnightly. They now meet monthly, and the model is that there is subgroups for each service area. Focused modelling discussions, so they're taking different formats. We've provided in consultation some terms of reference for subgroups. I won't lie, it's been quite challenging to coordinate that work. I think, understandably, the people who are delivering these services are massively clinically busy. There's a lot of demand on their time. They don't have the kind of time dedicated to be able to dedicate to this kind of work. So we've had that's probably been the most challenging part of the review is a kind of ongoing supporting people to take the time to be in those groups, how people want to present their suggestions and ideas back to us. Some people feel quite strongly that they would like us to provide a fairly structured set of, not instructions, but I'm going to say instructions because I can't think of another word, of how to present it back, whereas some people feel more confident to kind of do their own thing and then feed it back into the wider process. So going kind of issue that we're working on. In terms of a consultation, this is a very brief take on this. There's a number of papers and summaries of the level of consultation and where we've consulted. But there's been a large scale service user, carer, stakeholder and public consultation. There's been extensive digital promotion via the Trust comms. So we've had it in Connect 3 times. We've had it on all of our social media channels. We've been through, David and I have gone to various meetings, Sunrise and other meetings to try and engage with people. There was Jo and her team kindly spoke to people about opportunities to get involved during co-production week, and we also sent out hard copies of the survey, which also had a link to do it online, to over 4,000 people. I'm assured when we got the bill for that was the largest single mail out that was done in one day from the Trust that anyone could remember. So I'm sure that made me very popular. So we're currently in the analysis period. The online consultation closed on the 16th of October, and this week, today actually, is the closing date for the hard copies to come back in. We gave an extra week for people to send that back in, and it was all to a free post address, so it didn't cost anything for people to contribute. So we're currently in the analysis period for this week and next couple of weeks, and by the end of that time, we will have produced an initial report on the themes of the consultation. What are the main issues people are bringing up? There'll be some quantitative information because there were some questions that were scores, how's your experience been of this service from 1 to 10 and things like that. It was a mixture of that and very open questions. And we focused on giving people the opportunity to free text feed in their views, because I think something that can happen during consultation processes is if you ask enclosed questions, you can end up doing a whole reconfiguration, and people have never really had the opportunity to feed in the more nuanced things that they find difficult about those services. So we asked people, what's good about those services and that's been helpful to you, what's not been helpful, and what would it look like to you, what should it look like, give people that opportunity to make suggestions as well as just rating the current arrangements. So once we've done that, we will be providing those back to groups for them to use that along with their own views and their own work that they're doing to propose some initial principles of models back to us by early December. And that's by far the end of it. That's a kind of initial stage of us using the consultation and the much more in-depth views of people who are working in those services to try and bring together some initial suggestions. And we agreed at the last project board on Monday that we would facilitate and provide admin support to make sure people could have some sessions booked in and some time in the diary during the weeks that's available, to make sure that they can do that. So then it's mine and David's job to pull all of that together, to start proposing what things could look like. And then that goes back out for another consultation. We're really keen. Again, as I say, I wasn't involved in the process in 2017, but one of the feedback that felt quite strong when we spoke to people was that they felt that their ideas were being sent into the void almost, and that there wasn't a back and forth process, they felt, where they could see their views replicated in what was proposed back. So, and I know there's a lot of strong feeling from people who are working in those services, people in receipt of those services, about some of those issues. So I'm highly conscious of that, and so is David. well, the whole project board is. So the general kind of end of the project is March 2021, and that will be when we've had the response back from our initial principals, and we pull something together that encapsulates as much as possible what people have suggested, and obviously that will then need to go through due process, both from the trust point of view and with partners, for example through the Mental Health Partnership Board and our commissioning organisations, because inevitably when you have your ideals, you necessarily match what our commissioners want, and we do have to ask people for some red lines. You know, what can we have and what can't we have, and what's completely impossible. And something that we did with people that spent time with us, you know, kindly giving their time in the substance misuse consultation, was we did a report afterwards saying, you know, this is what people said, this is what we do based on that. We weren't able to do these things, but this is why. You know, and I think it's respectful to tell people why you can't do something that they've suggested, rather than just feel like nobody's listened in the first place. Now, we've got, last count, it was just under 500 responses that were being input into online. So obviously we're not going to be able to do every specific suggestion, but we're trying to be sensitive about that. And after that happens, obviously, you know, once we've been through due process and agreements are in place and it's able to proceed, there will be a different process that has to happen, and that has to look like more of an HR led process about consultation, because of course inevitably there will be impacts on what the teams look like. So the priorities really, and I will stop talking and let people ask some questions after this line, is to try and do the consultation right. There's always people we'll miss, and we are conscious of that, and I don't think you can do a perfect consultation. Feedback to people and try and communicate and manage people's expectations, but it is a really complex and contentious issue to address and project to work on in a lot of ways. So you know, we're just trying to make sure the maximum opportunities are there for people to input as best we can. I'm going to take a sip of water now, and I think my next slide just says, has anyone got any questions? Okay, let me put my list of people up and then I can see hands. Okay, so I think Richard, you were first.
Yeah, thank you. Can you hear me okay?
Yeah.
Yeah, thank you. I'd like to start by giving you a personal apology over this, because I think as a member of a board, we spent a lot of time discussing this, and we genuinely thought it was going to improve services for service users, and that patently hasn't happened, and I'm sorry that we failed you on this occasion. I think that's, and I know that the other non-execs who have left the organisation would strongly agree with that as well. We've done a great deal of reflection since then. There's a lot of learning. Some of it has fed into quite fundamental things like our CQC rating, and we've had some massive big changes to our senior management team since then, both executive and non-executive. So I think we're really keen to get behind you in terms of trying to get the best service model we can within the constraints that we're operating within. We know that's a challenge. We know there are different views, but this is a really important service, and I think we need to take time to get it right, and we need to keep learning from best practice elsewhere in the country, as well as what we want to do. So I think you're absolutely right, Helen. You know, it's not easy, it's very complex. We can't do everything, but I'm very optimistic that we can learn some of the lessons about why the implementation of what seemed like a good idea went significantly wrong, in my view. So thank you for that, and I'll be happy to listen and take on board what you're saying today.
Sure, thanks, Richard. I think probably just to add to that, that's prompted me of a couple of things that I've probably missed out in the presentation, was that we are obviously alongside looking at all of the input from subgroups and the consultation, clinical guidance, best practice, recommendations of our clinicians, as well, about making sure that we've got a mixture of what people want, what's right, what's clinically effective, what's quality, but in the constraints of what our commissioners can pay for as well. So yeah, no, thank you for that, and I appreciate that, and I know I wasn't around at the time when that happened. Okay, so Sandy next.
Hi, thank you. My question is really something you touched on at the beginning, which was about the fact that there's clearly overlap with lots of other services in relation to this work. No, it's not a separate island, these services that are being looked at. And you've been talking about it in terms of the services. And my question really is, well, I've got two questions. One is about the link to other pieces of work going on in the Trust at the moment. And I'm thinking particularly about the new models of care and the work with primary care, which I think, has a sort of potentially significant overlap, and how we are making sure that the work goes together, it's sort of, and is complementary to each other in terms of what we're going to end up with at the end. So that was something particularly on my mind, but there may be other pieces of work, a little bit more would be helpful about how we are ensuring that we're not going to end up with a proposal that then suddenly we find, cuts across other things that are happening, because we're in a fast-moving world. It's incredibly difficult to keep up. No service is static at the moment, is it? So it's about thinking, well, how can we incorporate all of that? And then, excuse me, the other question I've got is, one of the things we've looked at in the Quality Committee is the SHAR report. And I know there are a lot of different views and feelings about the SHAR report, so I'm not holding that up as something we've got to do. But one of the things I remember reading within that report was about when you start a change management, it's about knowing at the beginning what you want to see better at the end. So what are we aiming for, and how will we know when we've got there? And so have we got some statements somewhere about, this is where we are with this at the moment, and after any reshaping, this is what we want to improve, and this is how much we want to improve it by. Has there been some thinking about that? I mean, it won't be sophisticated and probably scientific or all the rest of it, but some 3 or 4 key areas that we want to make sure that we see a big difference in, and some of that will probably be staff satisfaction, but just sort of, what are the key things that we're focusing on to refer back to make sure that the changes we're making will really make a difference?
Okay, thank you. So I'll take them in order. In terms of the first one about the other work and the interdependencies, we've been well, not necessarily from the very first meeting, but I think now we're at a point where we've got the right people on the project board who are linking in from the organisations who are overseeing bits of work that are going on outside of the Trust. So, for example, Mel Hall, the Commissioner from the local authority, Heather Burns from the CCG. So they've got a citywide oversight of the work that's going on aside from it, and they're making a real good contribution to our work in the project board. Myself and David as project managers have been attending different kind of workshops and things like that that's been going on about the primary care transformation, for example, and we're well aware that that's going to impact, particularly in this piece of work, because we're looking at work on mental health going on at an earlier stage, and that impacts on the entry point to SPA community mental health teams. So those interdependencies, we believe that we are aware of the majority of them, that we've got the right people on the project board, and also that we've linked in with Tony Wilkinson about IAPT and how they're working and how the GP offer can sit under that. in terms of us kind of the end product that we present for implementation, I have no doubt that we're going to end up in a situation over the next kind of few months where then different people are going to end up, that bit's not going to work because it's not going to interdepend with that bit very well, and we're going to have to, that's going to have to be an iterative process, I think. Just because we can't, David and I are not going to produce something on the basis of all the consultation feedback that's going to solve things, and I think we're not unrealistic enough to think that. I think we just need to try and make sure that we continue to have everyone's buy-in and tweak things as we go along. And I think probably the other thing that we've talked about is that it's kind of the entry and exit points that are something that we need to be particularly focused on in terms of whatever model we do propose, because they're usually the things that have the most interdependencies with other things. We don't want to end up, in a situation. So when I worked in substance misuse, for example, we kind of stripped everything down to one phone number. I'm not saying none of the, this is a disclaimer, none of the things that I'm giving examples of are things that we're saying we're necessarily going to do, but out of the process we thought we need to just have one phone number. This is part of the issue that people are really confused about. So yeah, the right people, knowing about the big pieces of work, and an iterative process, making sure that we're flexible enough to be able to put in changes right up to the point of sign off. And I think also having a model that can, it needs to be clear, but it does need to be able to flex to other changes as they happen in the city. Because as you say, life's really fast paced at the moment. It's hard to keep up with everything. I mean, I couldn't, realistically, I couldn't list every single interdependency that there's sat with these, and I know it, I'm working on the project in detail. So it's asking people to come forward if they think there's going to be a conflict as well. The second point, in terms of the SHA report, we made a commitment at the beginning of the project and through the project board, which is minuted formally, that we would use the considerations, the recommendations, from the SHA report as part of our considerations of the overall consultation, and that will be reflected in any model that's proposed. And I think it's worth saying that, and this kind of links to your question about how do we know what we want to improve. We have got and use and looked at, a number of performance data that we monitor those services with, things like waiting times, just to use a more basic example. The things that kind of are showing in our performance data as things we wouldn't want to happen are the things that are being referred to by service users in the consultation. So it's, it's not, I don't want to oversimplify it, because there are a lot of nuanced issues that are coming through as well. But broadly, there's kind of some themes that are just consistent across every single bit of feedback from every single group of people and from the performance data. Which I think is a good thing, because I think it means that we've got an area to focus on those particular things in a remodel, because there's lots of things that do work really well and are really successful and are really helping people, and I think it's important that we we don't do something that kind of just says we need to throw every element of it up in the air, for the sake of it. So I'm quite reassured at the moment by what's coming out, that it matches that. And Michelle's just made the good point, about patient reported outcomes, which we will need to be using alongside what they're saying.
Excellent.
As well.
Can I have that's really, really great. That's very helpful. Can I just have a quick supplementary? Because you said about throwing everything up in the air. It does occur to me, I don't know whether there is any limitation in your thinking on scope about the boundaries between these teams. Saying we want another big restructure, but if there is something that in terms of reordering or reorientation of who sits where and who does what, is that fundamentally part of your work as well?
Yeah, I mean, the scope is the model in which SPA, EWS, North and South Recovery work. So really, you know, it's on the table in the sense of if it's involving that service, then it's on the table. I just don't want to come from a position where we're assuming from the beginning that that's what's going to be the outcome.
Yeah.
That people want a massive wholesale change when potentially we could achieve some of the things that we need to right that have been wrong through less dramatic change, I suppose.
Yes, that's wonderful. Thank you very much. That's been really helpful. Thanks.
No problem. Heather?
I think it was Lee first, actually.
Oh, my apologies. I'm just Lee. Would you like to go first? So my apologies.
Heather, you can go first if you like.
Okay, all right, here I am.
I'm causing chaos on the question.
No, don't worry, it's fine. One of the things that I do on the board is I chair the people committee. So I'm really got my focus is very much on how staff are feeling about things, what the culture is of the organisation, all of that kind of thing. And I do realise that the previous reorganisation of these teams did lead to a significant problem with that. I think what you're doing there about consultation and things all sounds great. But I suppose my question is, how's it going with respect to, you know, how the staff are feeling about things? And have you got any ideas of things that perhaps could be done, you know, slightly more going forward in order to try to address, I guess, what are issues to do with trust, confidence, owning, belonging, all of those kind of things, which would make people feel more on board with the trust direction?
Yeah. I think, how's it going? It's mixed with staff. I'll be honest about that. It's I have the sense that quite a lot of trust was lost during the former process, and that's, well, it's not just a sense, you know, people have very explicitly said that. I'm just trying to think of the right words to use, really. I think people had a bad experience as part of the previous reconfiguration. They are, and when I say people, I'm of course not talking about everyone, but I'm talking about, you know, a significant amount of people who feel that whatever process we do, it might end up that they feel exactly the same as they did last time, and it's been very difficult to provide assurances that they're sincere from our motivation, but that feel sincere to people who feel so strongly about something. So I think what we're trying to do is kind of take feedback in each meeting from the subgroups about any support we can provide. So for example, we've initially we tried to minimise kind of management involvement in the subgroups, i.e. chairing them and things like that, because we didn't want it to be seen that we're trying to take over, you know, the SOMs or us as project managers trying to take the subgroups over as well as the project board, to give people the freedoms to have the conversations and to present what they wanted to back to us. However, that's provided its own challenges because people lose clinical roles, and so haven't necessarily got time to oversee subgroups in that way and provide them with the structure and kind of project manage that element of it. To which we might respond by providing some more structure, which then can be perceived as us trying to take over and steer the direction. So it's been a very kind of difficult. It's been quite difficult. You know, there's no other way to describe it probably. I mean, you know, from my point of view and from the project board's point of view, there is a genuine intention to use the consultation outcomes and the staff, you know, and the staff being a really key, of course, service users, but staff are key in this too, and they feel very hurt, a lot of them, by the former process, and that their working life has been affected, the quality of their professional life has been affected by it. So we're trying to, I suppose we're going through a process of trying to deliver quite a complex change process while getting people's trust back.
It is really tough, and I think lots of things you're doing there sound really good. Just a couple of points that have come up in the discussion already. I mean, you talked about it being an iterative process, and it may be that by giving feedback a deterioration, that begins to build trust again. You know, it's kind of, you said we did, you know, people are listening, that kind of thing. And the second thing is just to pick up on the point that Sandy made. I think almost having that vision, you know, what we really want this to look like and feel like, you know, that can bring some people on board, and it will just be, you know, a few people here, a few people there, different things will work for different people. But, you know, obviously this is something that is really critical, isn't it, in order to be able to bring staff with you. And it is a tough ask. And I'm not suggesting that everyone's got all the answers to that. Have you got organisational development on the board, on the, you know, your project board?
We've got, yes, we have. It's not, we haven't got Rita, but yes, we have.
Okay, that's great.
So we've got HR as well, who are holding us to kind of, are we doing organisational change in line with how we said we'd do it?
Right. Yeah, thank you.
Okay.
Thanks for what you're doing.
No worries. Lee, definitely your turn now.
Yeah, I'm not letting John jump in.
Right, Mike goes. So
yeah, there's loads to say. Probably the first thing is I found it really interesting, your summary. For what it's worth, it sounds like you're approaching it in a really positive way. And what comes across as you talk about it is just genuineness and transparency and honesty. And I think that goes a long way to building relationships as you progress with this. I think just picking up on some of the discussion around the outcomes, because I'd be really interested to, maybe not here, but think about what the outcomes are from this work, because from my experience, that really guides the questions that you want to ask, and then the answers to those guide the interventions that'll help. Mm-hmm. So, for instance, and they don't have to be too wide ranging, but access times is probably one of the outcomes. Manageable caseloads within the community teams will probably be one of the outcomes. And thinking about actually how you measure whether or not these changes are having the impact, but then accepting that from day one, the changes that we've put in place might not have the desired impact. What's important is that we learn as we go and evolve. So we talk about iteration. That's not just before the start of the go live, if you like. It's after the go live as well.
Yeah.
I was really pleased to hear you talking about the access, but then caveat that with it's the end of the pathway as well, and how people leave services. Because I think the mistake we've made lots of times in the past, and we do it right across the NHS, is focus is always diverted to the front end of the pathway. How do we get people to the door quicker? But actually, if we don't focus on how people leave the service, we just end up with a growing follow-up pool that becomes impossible to manage. So yeah, it was good to hear that. And then just my final point is we're learning so much through COVID. And I just wondered, because the timing is kind of like with the consultation is aligned with COVID, isn't it? And I just hope that lots of the learning that comes from COVID, there's time for that to feed into what the outcome would be. Because for instance, some of the services that I'm working with that are looking at reducing waiting times, actually the conversations evolved to say we want to improve access to the service, but we acknowledge there's always going to be some waiting. We need to make that wait as useful as possible and for people to feel connected. And what I'm hearing from teams is the way we've responded with MS Teams and so on actually provides us a real opportunity to engage in waiting lists in a much different way. And I'm sure you've thought about it, but just to hope that all of this learning since March can feed into what the eventual solution is.
Yeah, thanks for those points. They're really, really helpful. And you're right. I think, you know, in terms of the end of pathway stuff, we do need to, and we'll look at destinations from those services and what they look like, and whether we're working with people as well as we can be about that. But yeah, definitely. I think, you know, it's been a long year, you know, and we've all had to learn to work really differently. But I think you're right. There's a lot we can take out of that about how we can communicate with people while we're not delivering formal interventions to them. that doesn't require as much staff time, travel time, going to see people, things like that. It's opened up options of being able to communicate with people that we probably never would have considered before. So yes, definitely that will be a consideration. So is that okay, Lee? Are you happy with that? Yeah. Okay.
No,
thanks.
Great. Thank you.
No worries. Jonathan.
Hi. Thanks. I'm afraid I don't have the same cute background noises that Lee had there. No little kids in the background. Helen, just before I make the point, are you happy for us just to keep discussing like this, or is that what you want for the rest of the session? Because I'm happy to hold my point if you want to take back control.
No, I don't want control. Thank you.
Okay, right, fine. So just to give a little background of where I'm coming from. So I work in kind of clinical standards and quality at the minute, but my background is a social worker, and I used to work in CMHT at Eastglade. So all of this has been very close to my heart for many years, and I've seen all the ups and downs and at least two reconfigurations. I wanted to bring in the point, to emphasize the point about things being person-centered and clinical based. An observation that I've thought over the years is that often when we come to do our reconfigurations, not just of our CMHTs, stroke recovery teams, whatever we choose to call them, but of other things as well, it tends to often be a bit service based. So we will decide on how we want to configure our services, which I think can sometimes lead to us missing the point. And if we don't make it enough service user based, we don't bring enough of that stuff, the pathways like Sandy was talking about before, or what we really mean by the outcomes. So, the point that Heather was making about staff, absolutely, we've got to make sure that staff are happy with things. I would suggest that what staff want is to come and do the best for their service users. And so what really pisses people off is when they feel that things are getting in the way of doing the best for their service users. So what are the real outcomes we're trying to achieve? And it will be stuff about good care for our service users. An outcome shouldn't necessarily be, for example, a certain size of caseload. We might want that, but what's the point in that? The point in that is so that we can deliver the best care we can for our service users. Why do staff get pissed off when they've got too big a caseload? Well, because they can't manage it to deliver right care.
Yeah.
So I think it's important that I haven't really got a question with it, but I'm just making the point that I think it's important we have that focus, and we keep on reminding ourselves what is the benefit of this thing we're talking about, or this change that we're making for the service users that are on the receiving end.
Yeah, I absolutely agree, and you're right. They're inexplicably, you know what I mean, linked. Because you're right. It's not just about us saying we need to achieve X caseload because that's fine for staff and that's what staff want. Because you're right. The reason that staff want a reasonable size caseload is so that they've got the time to give quality support to people. And the reason that people are feeding into the consultation potentially is that they don't get enough time with their worker is because the caseload is too high. We're talking about the same issue. From the 2 points of view, they just look slightly different, because depending on which side of the fence you're sitting on, it depends whether you know what the cause of that is. And I think you're right. And I come from a background, where outcomes and data analysis and the things about us having to report certain outcomes is a necessity, but it's about understanding and making sure that we're prioritizing what the reasons are for that outcome rather than it being a box ticking exercise. I completely agree. And obviously we're I can give my personal, I'm just one small part of this overall review process. My motivation is certainly to do that as best we can. We won't get it. Nothing's ever perfect, and I think sometimes we've ended up in a situation where the seeking the perfect has ended up affecting the good. Well, that's not quite the phrase, but it's something like that, because you can't get everything. There's so many moving parts of the interdependencies that it's really challenging to do that. But that's a really long-winded way of me saying I agree with you, John.
Can I just come back in with another little thing, and that's just to make an observation that a lot of this isn't our fault. I just wanted to make the observation that there isn't proper. I'm not sure who's on the call, so I'm not sure how well this will go down. There isn't proper specification for CMHTs. I think our commissioners need to take some responsibility for never really having properly specified what a CMHT should look like. But it's not necessarily their fault, because nationally there isn't proper specification for what a CMHT should look like. It's always been a case, and I think it's increasingly the case, that the policy attention, the money, all the rest of it goes to kind of sexy bits of services, things that we can define nice and easily and get nice, easy, straightforward outcomes on. And CMHTs have always been the dumping grounds. I just wanted to make that observation that, yeah, we might feel like we're in a bit of a mess with this, but we shouldn't take all of that as being our fault. We're not the only place in the country that struggles with this.
Yeah, that's an important point about commissioning, actually. And I think, as commissioning of mental health services is not commissioning as I know it, and the commissioning as I know it as the previous substance misuse commissioner, which was very clear, and we specified services extremely clearly in line with clinical guidance and best practice. And there was a whole suite of resource, and we had a commissioning team to work on drugs and alcohol in the city, and that resource and that the boundaries in which we were able to operate meant that providers had to come to us when we did a tender process. Now, I'm not suggesting for a second we start tendering the processes. That's not what I mean. But because there was a tender process, providers had to present the model and how it would meet the national clinical guidance, how it would be adequately staffed, and as commissioners, as a previous commissioner, I would expect to be setting out in line with that what things should look like in order for them to be good quality. Mike, you've put a comment in. Do you want to come in here? Because I know that you're. Apologies, I should have brought you in earlier, as you're part of the review.
No, I was just agreeing with what Jonathan said, really, because I was in the review last time. I went to lots of the meetings, and we did say the same things, that we need to clarify what is our service offer, what are we hoping to achieve, and the recovery kept being put back and put back and put back because the other teams where they have national guidance are easier to define. So they all got defined, and by the end of the redesign, we felt we were set up that we have a recovery team, but with no inclusion criteria, no goals, no clear steer. And then we started trying to make sense of it after the redesign. And at the same time, no managers were put in place till several months after the redesign. So I think that's part of what leads to this lack of trust. And I think the outcome has been, certainly from a personal point of view, I've had the worst 2 years of my career over the last 2 years, and lots of people have left for that reason. So we need to bring people on board. We need to have their trust, but we need to be very specific about what we do and don't offer, because like Jonathan says, we then become the dumping ground. I suppose the only other thing is, it's really difficult as a clinician because this is all a completely different language and a different way of working. I've got no background in project management, so when I come to those project meetings, it bamboozles me. And it's how we translate what I know about what's clinically needed, what service users are asking for, to that meeting where it's reports and grids and things that are amber and red and green, you know, all the things, how we translate, you know, that meeting into what service users and care coordinators and support workers and everybody is, you know, knows what needs to be delivered.
No, thanks, Mike. I really appreciate that, and I'm really, you know, I feel for you and colleagues saying that it's, you know, that it's been the worst period of your life, and I'm so conscious of that in this process, you know, and carrying a lot of wanting to get it right. But I agree with you about having to be honest, the project board bamboozles me quite a lot. I probably shouldn't be saying that, but you know, that's the vehicle through which we have to deliver kind of process, you know, decisions up through the decision making processes. But the real issue and the real work will be what comes out in the model. And I'm happy to. You're right. We get into management speak, and it's really unhelpful. So I'll note that, and I'll have a chat to Phil about that as well, regards to the next meeting, because you're right, that's a fair point. It gets very management speaky and project management speaky. Go on.
Yeah, it's just because it is all management speak and all, like say, bamboozling, I don't come away from those meetings understanding what we've agreed or with something concrete. And Joe Evans, who's I think is on the call, knows that at the end of a meeting, I like something very firm and concrete and black and white, because I'm quite simple like that. So coming away from the meetings, you know, not really understanding, well, who's making that thing happen? Who's actually, how does what we've talked about in very odd terms turn into supporting the other groups to get to what they need to achieve?
No, that's a totally fair point, and I'll speak to Phil about that. Reduction of management speak. Also, we need to capture I think what's happening as well in those groups is that we're having the discussion as we go along. Our admin are kind of picking out the actions for the notes because they know they also speak project management speak. Lucky them. But then we're not summarising the actions and who's taking the lead at the end of the meeting. So those 2 points I will speak to Philip about as chair. I'm writing them down. That's why I'm looking at my desk, not you. Okay. Is there any other questions? I'm aware we've got just a few minutes left. Richard?
Yeah, I think I just wanted to support everything you've said, Helen, and indeed that colleagues have said. I think there are real issues about clinical involvement, how that works, and how we then use that through our system processes, because redesigning services, as you said, is complex. And I think if people, and in particular clinicians, don't understand what we're doing and are coming away from meetings not understanding what's happening, we have a problem still. And I don't minimise that, because I think that it's quite hard to marry these two things together. But I think if clinicians and staff are not feeling that they are understanding this, we've got to somehow find a way through that. Because I think, you know, underlying a lot of this is that, you know, we all want to do the best we can for service users. And I think one of the issues is that, you know, we know that compromises do have to be made. We don't have unlimited practice, particularly if we've got staff, you know, we have issues about staff recruitment. So there have to be, you know, there do have to be compromises made. But I think what we want are compromises that the clinicians, staff and ourselves feel are the best we can do and are appropriate in the circumstances, and that we can explain back to service users, who I genuinely think often don't want the world. They want something that's going to make a difference to them. So I think we need to reflect a bit more as well, you know, a bit more about how we continue this and how we overcome the issues, because I think we're on a journey here. We're getting some things right now, but I'm still hearing quite a lot of people feeling that it's got quite a long way to go. So I don't want you to get to the end of this service redesign process, come out with something and go out to consultation and just get the same stuff back again, because then that's not, you know, we've got to try to get on top of this before we go out to consultation again.
Yeah, I agree. I agree, Richard. I think, you know, you're right, and I take that feedback seriously about the meetings, and I will have a discussion with Philip as the chair about that. And I think part of the reason we made it iterative, as we said earlier, was because we would do want to be able to go back and forth a bit more, because that's more of a process rather than just say what do you think, and then everyone tells us what they think, and then they don't hear any feedback until there's a model presented, and then that's almost, you know, this is the model now, rather than there being some back and forth built in. So obviously we've yet to test because we haven't done it yet, and we're just at the beginning of that back and forth process about whether that will work or not. But that's the commitment behind that, is to make sure that we don't just end up in a one-sided process where we ask people to give us all of their thoughts and expertise and feelings, and then we just present the final model. We want to go back and forth and have a negotiation. I say negotiation, that's probably the wrong word, because we're not necessarily coming from a different point of view either. Yeah, so I agree, and I will pick that up with Philip. And Mike's just suggested we score the meetings at the end like you do in microsystems. I've never done microsystem stuff, so I don't know about it, but that will certainly keep Philip on his toes, the chair.
I mean, it's a slightly flippant point, but at the end of every microsystems meeting, you say you give it a score, which Joe knows my scores are always very low, and then you say what went well and what could be done better. And so otherwise meetings just carry on and with everyone being dissatisfied.
Yeah, that's a good point.
Oh,
and yeah, well, I think actually, you know, you've brought this point up about the meetings, which is totally fair enough. So maybe that is something we need to do as part of the next meeting, because then it sets a change, doesn't it, in how they're held. So yeah. Joe?
Yeah, picking up on that, can't resist to come back on that, Mike. But yeah, in all seriousness, I mean, we do have a sort of a joke about it, but in all seriousness, it is a really, really helpful tool, and I'm very happy to talk to you about that, Helen. It's very simple, but it does kind of help meetings in terms of people don't leave the room chuntering about things particularly. You know, you actually kind of air it in the room and say what's gone really well, so don't change that for next time. Or actually, you know, if you want me to come again, then this is, you know, so yeah, I know it was a little bit, I think Mike was sort of saying it a little bit tongue-in-cheek, but I think it is a really helpful tool, actually. So more than happy to have a chat with you about any of the things that have come up as well today in terms of the improvement side of stuff as well, Helen. Thanks.
So we've neatly come to 10:29, so I probably need to leave you all to get on with your days now. So thanks for having me and engaging in the session and listening, and for your feedback, which I've made notes of, and we'll take you up on that.
Thank you, Helen.
Thanks.
I'm just going to share that last slide again, if that's helpful, if anybody wants Helen's contact details, if you want me to do that, Helen.
Yeah, just drop me a line as well if there's out else that you want to bring up, or you want to you know, ask or get involved, anything like that. More than happy. Great.
Brilliant. Thanks very much, Helen.
Everyone.
Thanks.
Bye. Bye.
Thank you.
Bye.
Bye. Bye. Thank you.
Thank you. Bye-bye.